will continue our lecture. Lastly, we said that there is squamous cell carcinoma and adenocarcinoma of the cervix. The spread of the tumor usually occurs through the lymphatics down to the vaginal wall, laterally to the parameterium, and anteriorly to the bladder, posteriorly to the rectum. The lymphatic then drain these cells into the external and internal iliac lymph nodes, to the obturator lymph node, and then para-aortic lymph nodes. The blood supply is with lesser incidence of spread, mostly is lymphatic and direct. The treatment of cervical carcinoma. We have surgical, we have the preclinical lesion, usually the patient with invasion less than 3 mm depth and 7 mm width, and this can be treated by local excision in the form of cone biopsy, LEEP, or cryotherapy. And the patient with disease invasion between 3 and 5 mm depth and less than 7 mm width can be suggested for radical treatment by total abdominal hysterectomy. Invasive cervical carcinoma, either by radical surgery, we call it VACCINATION, or by radiotherapy or combination of them. For the disease confined to the cervix, there is either surgery, especially if the patient is in the premenopausal age group, or radiotherapy. Both are equally effective, but it depends on the skull, because this radical surgery needs skilled person and fit patient. So it needs good skull and facilities available in the center you refer to. Once the disease is outside the cervix, it means later stages, it should be treated by radiotherapy, as the result for both is the same. This is the LEEP. We use loop of cauterization and we cut in a cone shape area. The surgery, the standard operation, is called VACCINATION hysterectomy or radical hysterectomy. It involves the removal of the uterus, paracervical tissue around the cervix, and the upper vagina, with the removal of as much as we can from the pelvic lymph nodes, involving the external, internal, and common iliac lymph node, obturator, and the presacral lymph nodes. So it needs a skilled surgeon and good facilities to remove all these parts. If large number of lymph nodes are involved, adjuvant radiotherapy can be offered, but the dissection and its removal will be enough. Ovaries can be conserved, especially if the patient is young and the disease is of squamous type. The radiotherapy, by applying radiotherapy directly or centrally to the tumor, and external therapy to cover the pelvic spread. This can result in good control of the disease with a few complications like diarrhea, radiation, menopause, loss of elasticity of the vagina. So this mode of treatment is better to be preserved for old ladies, because usually old ladies are unfit for GA, for having radical surgery. That's to say, the morbidity of radical surgery will be more for the old persons. Nowadays, addition of chemotherapy offers additional benefits to the patient. Radiotherapy can be also offered for patients with advanced disease to provide palliative treatment to reduce the vaginal bleeding or discharge. This is in late stages usually. And this is the external beam therapy, pelvic radiation, and the internal one by using special electrodes put in the vagina. There is another operation called pelvic exenteration, which is more difficult and sophisticated operation with high rate of mortality and morbidity. In selected patient is done after radiotherapy or those with recurrent disease that spread to the bladder or rectum but without distant metastasis. It involves removal of the growth and the recurrent growth, and sometimes they remove the bladder and do conduit to the ileum, or sometimes they do colostomy also. Anterior exentration involves the removal of the uterus, vagina, bladder, and implantation, as we mentioned, of the ureter into the artificial bladder from the ileal loop, and the rectum is removed, and this is called total exentration with colostomy. That's to say, anterior exentration, removing the bladder and vagina with it. While if it involves the removal of the rectum, this is called total exentration. Palliative treatment, especially if the woman is unfit for operation or in advanced stage diseases or in recurrent diseases, it needs expert nursing staff, and the aim is to keep the patient free of pain and comfortable as much as we can by providing codeine, pethidine, painkillers, and similar analgesia, phenothiazines for nausea and vomiting, and sometimes may need nerve blocking procedures medically or surgically. The prognosis depends on the methods of treatment used and the experience of the radiotherapist or the surgeon, and on the country and the stage of the disease, because it needs special skills. We have to prevent the disease rather than treat it, because it will be much better to have a prevention rather than treatment. The preventive measures involving avoidance of early marriage, avoid early and frequent intercourse, strict avoid monogamous relationships, and restriction of the number of children, improvement of the genital hygiene, periodically clinical cytological screening programs, and good obstetrical care, avoid smoking, no harm in pregnancies. And nowadays they advocate vaccination abroad. This HPV vaccine, we have 3 shoots over 6 months for the male and female between ages of 11 to 12 years up to age of 26 years, hoping that we will get such vaccination in our country. This picture shows to you the stages and the prognosis, and we all know early stages are very good, associated with very good prognosis, and this is why we should concentrate on the screening program to decrease or to discover the disease early, and so decreasing morbidity. And thank you.